Welcome to the St Emlyn's podcast. I'm Ian Beardsall, and this is another episode of the podcast recorded live at the Premier Conference from Winchester in June 2024. And in this episode, Ed Langford discusses neuroprotection in the pre-hospital environment. Ed is a higher specialist trainee in emergency medicine and also a qualified critical care paramedic, as well as being the managing director of Enhanced Care Services. Enhanced Care Services is an organisation based in Southampton that offer both frontline ambulance operations across the south, extensive medical cover to some of the most prestigious events in the UK, as well as bespoke education from their centre in Southampton. They are an excellent organisation. I really can't recommend them highly enough. So if you're interested in being involved in the pre-hospital world, whatever your role may be, I would click on the link that's available in the blog post. And now I'll pass over to Ed and a bit more about how we can look after children, particularly in the pre-hospital environment with head injury, and do our best to make sure they have an excellent outcome.
I'm going to talk to you about neuroprotection in the pre-hospital phase. I work for three organisations. I'm an EM trainee in Wessex, currently working at UHS. I work for Dorset and Somerset Air Ambulance as one of their critical care practitioners, and I happen to work for Enhanced Care Services, and we undertake a lot of pre-hospital critical care in the event sector. And neuroprotection as part of that is quite important because we see presentations there that we don't see anywhere else. We know that paediatric head injury, there is a significant burden, and it's one of the most common reasons for attendance to the emergency department, certainly in relation to trauma. It also accounts for around 30% of traumatic childhood deaths. It's Friday afternoon, it's 22 minutes past 2, and you are on the west side of Poole. There is an RTC at that junction, and a pedestrian has been hit by a car. He's 13 years of age. A 909 call gets made at 14:24, and a paramedic ambulance arrives at 14:27. For those of you that don't know, since 2017 there's the ambulance response programme that essentially categorises calls. This child was found to be unconscious with noisy breathing, and that categorises as a category 1. So the call taker is rapidly entering some information and is dispatching an ambulance at the same time as taking more information for us to know about. They have 7 minutes to arrive under the new times, and the ambulance obviously arrives in good time. And this is where neuroprotection begins. So they arrive, you've got a paramedic and you've got an emergency care assistant. A paramedic being your ALS provider in essence, and your emergency care assistant being your BLS provider. They arrive on an ambulance and they find a 13-year-old boy, GCS 3, and then becoming increasingly agitated shortly afterwards. They do a jaw thrust and they open his airway. That's the first point at which that patient's airway has been opened. He starts to have regular spontaneous breathing, and so they apply some high-flow oxygen. So oxygenation and ventilation neuroprotection strategies begin. Assuming there's no enhanced and critical care, you've got a paramedic ambulance, and these guys are great. They deal with difficult situations. You can imagine the chaos on scene at this point in time, and they're the only two healthcare workers on scene. If they had no further support, and assuming this maybe was out of hours, so beyond 2 a.m. really in our region, you wouldn't get any additional support realistically beyond an ambulance crew. This child is agitated, they're difficult to manage, and they have a difficult to manage airway. So the reality is that ambulance crew would be entirely correct to attend their local trauma unit, which would have been Poole. That means that you working in a trauma unit may receive a poorly ventilating, highly agitated child, and it's not for the lack of willing of that paramedic crew wanting to do more for that patient, but they just physically can't in their scope of practice necessarily add a huge amount more in terms of neuroprotection. But thankfully it's Friday afternoon, everyone's at work, so a critical care paramedic arrives at 2:39, and this is where neuroprotection then can continue. So they get a quick handover, they understand that this child presenting in front of them is critically unwell with a neurological injury. They get him skin to scoop, so all his clothes are cut off, large bore IV access, tranexamic acid under a standard paramedic scope, currently 1 gram. Our guidelines would be 2 grams for an adult, and then obviously weight-based for the child, and they continue that neuroprotective strategy. We have a really good system in Dorset, so that critical care paramedic knew that the critical care team were flying into this patient, and actually their strategy was, we need to get this patient to definitive care as quickly as possible, but in order to effect that, actually we need to package them, we need to stabilise them. This child is very, very agitated, so let's get prepared for an intubation, an emergency anaesthetic, plus minus some sedation prior. So at 2:39, the aircraft lands with a critical care team. That is a consultant and a critical care paramedic or practitioner, and they landed a short distance away in a field. It's not always that we can land right next to the patient, and we need twice the diameter of the dish to be able to land. And so that was the safest place that our pilots felt that they could get to. A short hop across some roads, arrive at the patient at 15:04. We're still relatively early into this child's journey at this point. They arrived to find an ever-increasingly cerebrally agitated child with a large scalp hematoma and sluggish pupils becoming larger to around 8 millimetres. So they provide some sedation. He gets 30 milligrams of IV ketamine straight off the bat to gain control and calm the scene, which the critical care paramedic, I think, was probably already thinking about and trying to move towards. And they arrive to a very well-packaged patient that actually has had lots of stuff done. They then progress to an emergency anaesthetic, get some ketamine, some rock, and then we can start to consider some slightly more nuanced neuroprotection. And we also load on Keppra for all children that we intubate with a head injury. So what does the neuroprotection strategy look like in the pre-hospital phase? Well, the reality is it's very similar to what we would do in hospital. The challenge is you're trying to do it with 2, 3 or 4 people in reality under quite a lot of stress to move towards an emergency department that's appropriate for this patient. As you can now imagine, he's on a ventilator, can do some more nuanced things, so we're avoiding some hypotension, we're adequately ventilating this child, and we can get an arterial blood gas, and I'll come on to that in a sec. We are ensuring adequate but not hyperoxia, so we're aiming for SATs of 94, and we can again tweak our ventilation strategies to get an appropriate PO2. A blood sugar was checked by the paramedic ambulance crew, and that was absolutely fine, and we're aggressively trying to keep this patient warm. Whilst we worry about patients getting too warm, the reality is in our environment, actually maintaining normothermia is super challenging. So this patient was wrapped in a blizzard blanket with heat pads, and essentially active warming was initiated. And then we want to think about our transfer to definitive care. So there's still some stuff we can do, but actually time is of the essence, and we want to go towards our major trauma centre that can cater for peds. So that's Southampton for us. The team undertook some further interventions en route, so rather than staying and doing everything on scene, going by road to some extent allows us to do some things. Although we now have a larger aircraft, it wouldn't be a pre-hospital talk without talking about the size of aircraft, and it's a bit of a contest. But the reality is we can do some stuff in the back of an aircraft, but sometimes it's easier to do it by road. I guess you might ask, well, why didn't you just fly this patient? You were probably at least 45 minutes to an hour from Southampton. Well, the reality is it takes us time to load patients in the back of an aircraft. It distracts us from doing some of the clinical stuff, and by the time the pilots have got the rotors running and we lift off, you would have been 15 minutes down the road by that point, and exactly the same in reverse, and then a trolley push down the helipad. So typically, if it's less than 45 minutes, there or thereabouts, we would elect to travel by road. So, hypertonic saline was provided very shortly after he'd been intubated, and pupils returned to 4 millimetres. Got a radial art line, so something that increasingly we're doing for a lot of patients, especially around neurocritical heads, to be able to manage their blood pressure accordingly. And we were able to get an ABG to consider their ventilation strategies in more detail. And he was maintained on some anaesthesia, had propofol and fentanyl for analgesia. And then at 16:11, this child arrives at definitive care. It comes to Southampton, gets handed over to the pediatric trauma team, and at 16:43 goes to CT. He does then become significantly bradycardic and dilates his pupils again and becomes fixed, gets a further dose of mannitol, and then moved to neurotheatre straight from CT. And actually, this child was eventually discharged with very, very good neurocognitive recovery, and was an absolute success story, which is hugely positive. I've highlighted at the top right of your screen the times from our database. And I think it's important to recognise that we all know how long it takes to do some of this stuff in hospital. And that's with a team arguably sometimes slightly too big to maybe deliver all of this care. But you can see that the on-scene time of our team, of the critical care team, was just 13 minutes. So when this comes together and works well, where you've got an ambulance crew that arrive, decide that this patient is critically unwell and they need some support, but can actually get on and do a lot of stuff that they're highly trained to do. You get a critical care practitioner that arrives that can add some value, drive the scene forward, and then you get a critical care team on top to effect that sort of level 8 care, intubate and ventilate that child, and then move them rapidly towards the definitive care. It does make a difference. And so that brings me really to the end and talking about the package of neurocritical care outside of hospital is very much similar to inside, but it's all about the drive to getting to where that patient needs to be, doing stuff on the way, and trying to be as seamless as possible with getting the basics right, opening the airway, applying some oxygen, and refining that as we go. A couple of things to sort of future direction. So direct to CT pathways. This child could have gone direct to CT if that pathway starts to become available. It's something that is coming online for adults, and certainly we have that available to us for isolated head now in Southampton. But paediatrics, we don't necessarily have that available to us. And those sorts of things will get that child into neurotheatres sooner. Thank you very much.